the IBM research lab in Zurich, so she has obligations for IBM, and she couldn't be here, so I have to take over her part. But she helped a lot in the preparation of everything, so I'd like to thank her for that as well. This session is on interpretability, explainability, uncertainty, and it clearly has a focus on medical AI. So I mainly work on medical data, mainly medical imaging. And what you can see up there is like what I think most people associate with interpretable AI. It's heat maps. So it basically, whether it's like a guided backpropagation or GradCam, it's methods that somewhat show like which parts of the image were taken into account for taking a specific decision on the image. So this is a high-grade glioma, and I took this from the article that I cite down there. It's a review article on interpretable AI with a focus on medical imaging. I just want to take a step back. So why do we actually need interpretability? I mean, when we look back at classical machine learning, much of it was actually interpretable because what we used were features that were based on human knowledge. And then when we look at distance measures, k-nearest neighbors, or even support vector machines, many of these things are easy to understand and comprehend. And we look at decision trees. I mean, this is something that has been used for many, many years, and it's inherently interpretable. But what we've seen over the last 10, 12 years is like a big shift towards deep neural networks, and everybody talks about ChatGPT. It started maybe 10 years ago, 12 years ago, with a lot of like on the ImageNet competition where deep neural networks had extremely good results and really changed the way that machine learning worked on many, many data types, not only medical data, but all other data types. The difficulty with deep neural networks is that there's no handcrafted features. I mean, it's a beauty that you can learn them from the data, discriminative features that work really well. There are millions, billions of parameters. I think the last version of ChatGPT has 100 trillion parameters. So it's very complex models. And we need to look into how can we now take one step back and get to something that we can actually understand. So this is basically the outline of interpretability for machine learning. I also wanted to take a few definitions, so just to look at interpretability or explainability. I took, again, like 2 articles here of Kim and of Miller, who defined it in one way or another. Quite often it's defined in fairly similar ways, that it looks at like how a human would then understand the outcomes of a deep neural network or could predict the model's results. That's more the Kim one. Explainability is very similar. Sometimes it's used like in almost the same way. Sometimes there's slight differences between it. But the idea is that explainable AI results in a solution that can be understood by humans, and it contrasts with the concept of a black box, which cannot be understood. And I think for medical AI, we can very clearly see why we need that. I think if clinicians need to trust AI, they sort of need to a little bit and integrate the outcomes of AI-based tools. They need they need some explanations of why the model reaches results, and also what is the confidence that a model has in its outcome. And I used the terms interpretable, explainable, but there are many, many other terms: understandable, intelligible, transparency, fairness, bias, accountable, reliable, trustable, robustness. And then we have related terms such as causality. I mean, how can we explain with causal relationships outcome, and also uncertainty, which is also in the titles of our session here, which can also help to understand and explain the limits of AI-based tools. And if you're more interested also in the different terminologies that are used for AI, we did a workshop 2 years ago that resulted in a paper. We developed sort of a taxonomy of different terms and how they are related also in different fields, from philosophy to sociology to legal aspects. I mean, it has many, many implications, I think, for all of us. I mean, European law has many implications on what rights we have. GDPR defines also that if there are decisions based on AI, like, for example, refusing a health insurance to you or a credit line of a bank, you have a right to have an expectation, something that you understand, that is clear why this decision was taken. And that's very important, and I think that will also change how AI will be used. And definitely there are quite a few other things come in the AI Act. It's again changing these things, and I think we will hear a little bit more about all these different concepts from the 4 people who will now present. So I think we can take it in this order. So we have Andre Angers of EDIAP from here in Switzerland. We have Dimitri Fari from Siemens Healthineers in the US. So he will join us. He's joining us via Zoom. So we'll give his presentation via Zoom and then also participate in the panel. Then Jens Klesig, that you've already seen in the first panel session, will give us a little bit of the perspective of a researcher, computer scientist turned clinician. And in the end, we have Mina Bielogric from the University of Geneva here, who's also working on explainable AI. So I will now give over to the next speaker.
Thanks, Henning. Thanks for the invite. Really a pleasure to discuss here. I just switch over. Can you switch the screen? Okay, so yes. Right. Then Control F. L. Beautiful. There. A bit of time. Okay, so try to be as quick as possible. I think Henning already did a quite good job on setting the ground for it. Just a little disclaimer, who am I? I'm head of the biosignal processing group at EDIAP. So the group is interested on applications. So the whole institute is turning around AI. So we have several groups. My group is more focused on the intersection between AI and health applications. I have myself a background in machine learning, computer vision. I've been doing this for the better part of the last 20 years. And we're particularly interested on looking into interpretability on projects where experts may originate from non-computational domains. So, explanations for people that are not really understanding what the algorithms or the underlying maths are about. So what kind of explanations do we want for healthcare? In my opinion, of course, we want the best models, so to be as accurate as possible, but you want as well these models to be comprehensible. But comprehensible to whom? To the expert, to the healthcare worker, which is not that trained on a particular detail, for the patient, for the insurer. I think we mentioned the insurer here many times in the past. So more or less experienced person. You want, of course, that those explanations to be consistent, okay? So that new models trained on the same task arrive at the same explanations. You also want this to be stable in a certain sense, so that if you have similar cases that represent the same risk, they have comparable explanations in terms of that risk. And to be certain, so this means that's well calibrated across different cases, okay? So this is nothing new. This was in this open source book here that you just saw. One of the use cases for explanations, in my view, is to support, of course, decision taking. I think that's the one use case that everybody thinks about. To think about statistical models, so this machine learning agents, artificial intelligence agents that are considered as yet another agent in the decision taking process. I think we discussed this in the previous session as well, on having yet another agent inside the decision process. Of course, we want these explanations to be comprehensible to the experts which are operating the machinery. But you also want that, for example, inexperienced professionals can learn from the accumulated experience that is encoded within these models, right? Of course, one of the benefits of this is that while you're less prone to variations in diagnosis due to fatigue or to the lack of experience. And of course, the added bonus is that these kind of models can be more easily corrected for, I don't know, fairness, since it was mentioned here today, safety, or even improve with time, right? And of course, keeping the idea that these models can be copied and redeployed quite easily. Okay. The second use case, which is a little bit more tricky, is the support for information discovery, right? So the idea is to build systems that allows you to understand, in essence, everything that we can understand, or as a a medical expert could understand, but can go beyond this and say, okay, this part here of the data is new, and I can't really fit this on my existing model, okay? You'd like as well that such systems allows you to understand better how these machines are working, and of course, do things like helping us debias existing solutions. Here are a few challenges, in my opinion. So the first one is, of course, that we may have maxed out simple explanations, right? So if you think about medical examinations, they are done to highlight points that a human operator can easily distinguish and reason about. So we are asking here the models to take the same examinations and to pull out more information that is easy enough for a human to understand, but that we can't really grasp. So that's a quite challenging ask for this particular domain, right? And the questions that you might want to ask is that if you start forcing, of course, the systems to be more explainable and understandable by a human, maybe this is going to also is going to constrain the performance of the system in such a way that it's not as useful anymore. Okay. And then, of course, comes the fact of understanding what is comprehensibility. I mean, how do you measure that, really? As of today, there are many commercial software tools already providing explainable information about how do they get to their conclusions. So here's an example for one of the currently available software solutions for detecting tuberculosis in chest radiographies. They can produce this kind of saliency maps where this is, okay, this is the region I use to base a little bit my decisions. But then we ask, okay, so what? What actually are you seeing on these areas that actually make you take that decision, okay? And then you may ask as well, okay, would a human doing this task would actually see the same, okay? And of course, then you have this contradiction or this dichotomy between do you want it to make more interpretable by human, or do you want to make it ultimately useful, okay? Okay, what about complementary information? So information that the humans do not know about, right? The other challenge I can think about is that very often help is needed not on the easy cases, on the cases that everybody can easily, or the expert can say, oh, this is easy. I know that the algorithm is right there because I can obviously see this correlates well with the disease I thought this patient had. The problem is, of course, going to be hardest on the harder cases. So how do you do exactly when you have cases which are close to the separation border, okay, where you actually have a doubt? And this is where explanations are most useful, right? And of course, this is hard because even the machine in this case would not be completely certain about that particular result. Here are some concrete results that a student has produced, and this is just to illustrate the fact that if you train a machine to reason about a disease, in this case here was detecting tuberculosis, and on the right side here of this table, you basically have the impression that the machine has on its own performance, and which is classified by different algorithms for the visualization of the reasoning about the decision. And if you do this, but just looking at what the machine thinks it's important, and if you try to correlate this to what a human thinks is important, you can see that the order and the values here are completely different between these two columns. So basically, this means that what a human would observe in the image does not necessarily correlate to what a machine uses to arrive to the conclusion, okay? And it doesn't mean that the machine that was trained is not accurate. So these machines, they all have more than 95% accuracy on the particular test database they were trained on. So I leave here some further reading and my contact information.
So then we can go to Dimitri. So you can maybe share your slides and give us the view of the Siemens Healthineers.
Yeah, let me do that. Good afternoon, everyone, and let me know if you see my slides.
Yes. Yes.
Okay, very good. Trying to see how I could put it in presentation mode. If not, then I'll just scroll through. Yeah. So thank you, Henning and Douglas Teodoro and Steve for the invite and for arranging me able to join via Zoom. I apologize that I can't come in person due to various commitments, both work and family. But I am confident that it's been a very, very stimulating conference up until now. And just listening to Andre, I'm already learning a lot of new things. So very, very exciting topic. What I want to do in the 10 minutes I was given was just highlight two works that we have done and published that look more at, the uncertainty question, right? When a model is uncertain, right, how can you tell, and how do you make sure that a lot of these, NLP models, I'm an NLP expert, as well as computer vision models, can be exact enough to say, hey, I'm very certain about this prediction, or I'm not certain about this prediction. The other thing is to also look at the fact that when it comes to explainability, interpretability, and uncertainty, as humans, one of the advantages we have over some of these machine learning models that we're training is we have knowledge, right? We try to infuse this knowledge into the models to see if they can replicate our reasoning, our ability to explain. But then we also have to look at, do we start a priori in terms of making sure the data is very, very accurate, the data used to train the models, or do we also infuse knowledge as we train the models? So the first work has to do with a radiology specific language model that we created. We called RADLing. And this paper was recently presented at the ACL conference this year, 2023. My colleagues, I acknowledge all the contributions here from my colleagues, both in Siemens in Princeton, where I'm located, as well as our colleagues in Siemens AG in Romania, who did this work. And here we're really looking at how we could, let me take this off the screen, how we could infuse knowledge, right? To be able to tell the model to detect when something is uncertain versus when it's not. And what we did here was leverage a way to, on top of the usual masking you would have with the transformer models, the encoder-based transformer models like BERT, which some of us are familiar with. Aside from the mask language modeling, we brought in a knowledge-aware masking. This was the way we decided to infuse some knowledge in how it's learning, and then try to test it on recognizing uncertainty within certain data and be able to pick that out. So just to give us an idea of what was under the hood here, we basically trained using over 545,000 reports, and these were across various modalities. As you would see in the graph, mostly X-ray, but we had CT, MR, CT angiography, ultrasound, and the graph on the right facing the screen gives you a breakdown of the different anatomies that were in there. And the backbone was basically using Electra Small. As we speak now, we've already used the Electra Large now, so we have a much larger model than at the time of this work. And what we did was basically leverage the generator discriminator backbone of the Electra Transformer encoder to be able to train this model. The knowledge infusion part, or the knowledge-aware masking, was really around taking some of these reports that were used in the training and then intentionally, but still randomly, masking anatomies and observation. Basically, the anatomies we're familiar with, Observation is the pathologies. If you see in this example, atelectasis, looking at your right of the screen, atelectasis is an observation, and then you have lungs anatomy, and then we had some different strategies of, masking mostly anatomies or masking mostly observations, and doing this all in the pre-training. By the time we then evaluated, using this kind of knowledge, knowledge-aware masking, which is the very last one, the one that says Radling KG, we saw that there was an advantage over both the state-of-the-art in terms of radiology-specific language models like RadBERT, as well as using your usual mask language modeling, the MLM, Radling MLM, or being able to classify sections in addition to your pre-training, your traditional pre-training task. So we saw an advantage using this knowledge masking. But where I want to draw our attention to is where we started testing. Okay, can you detect uncertainty? In the named entity extraction task downstream, we leveraged Mimic as well as ChestExpert for this evaluation. And we found that the observations that were not, that had some ambiguity, right, that were uncertain, which you would see if you can see my cursor, the observation uncertain, we found that the knowledge-aware version of our model did very well compared to the other versions that just use the traditional mass language modeling or did an additional classification of sections. It did much better, right? So we saw an advantage of infusing knowledge for it to be able to detect uncertainty. An example here would be in this sentence, by bacillar opacities may reflect atelectasis or consolidation. It was able to say atelectasis and consolidation should belong to the uncertain observation because it is not definitively stated here that that is what is found in the report. So this gave us an idea that bringing in knowledge, it might be able to say exactly when things are uncertain versus, some other methods. And then, like I said, the things we got from here is, the fact that if you infuse knowledge, it helps you with learning a new domain like radiology, but more importantly, it enhances the ability to detect where you have some uncertainty. And the other thing here, compared to RadBERT, our model was much smaller, and we saw that when you have smaller models with knowledge infused, you could actually get some an advantage over some of the larger models. So this is the first work I want to highlight. The second work has to do with computer vision, where we are basically trying to say at the data level, can you begin to filter out data that is uncertain such that if you begin to train models just on data that's very, very accurate and see how that matches up with the radiologist's impression of the findings. Here we're focusing on chest x-ray, chest radiograph assessment. And again, acknowledgement to my colleagues, Florin, et al., all wonderful guys who worked on this, in addition to our collaborators at Massachusetts General Hospital in Boston and Harvard Medical School. So the background here, like I said, it's about chest x-rays. We have 130 million chest x-rays done every year in the US, and the median reading time is about a minute 38 seconds. And you can imagine that already, makes this an error-prone process, because in a minute 38 seconds, people want to read this and move on to the next case, make a decision, tell the ordering physician what their diagnosis is, and they can go on to care for the patient. There's a lot of ambiguity in interpreting the chest x-rays, either because of the image quality or the inconclusive appearance of some of the abnormalities in the image. And more importantly, chest x-rays could be the first opportunity to diagnose nodules in the lungs. 19% of lung cancers with nodules that are about 16 millimeters in size can be missed on chest x-rays. And we know that that could lead to very unfavorable outcomes for patients. And so what we were thinking was, how do we address the ambiguity in reading chest x-rays such that we could train models that would be very exact and very, very accurate when doing this in an automated fashion. And so we looked at bringing in the theory of subjective logic, as well as information theory, in particular the Dempster-Schaeffer theory of evidence, where we would try to train a model to be able to generate an uncertainty prediction based on the data that the distribution of positive as well as negative evidence here. And the way we represented it was the U here is the uncertainty prediction, right? Looking at a binary classification where alpha is more of the positive evidence and beta is more of the negative evidence, or evidence around negative cases, and then alpha evidence around positive cases. So the higher the U, the more uncertain the model is about that prediction. And then what we did was now train a neural network to be able to predict that uncertainty when it looks at the data. And we added a regularization factor in there using the KL divergence, and also leveraged the task here. The training objective was to optimize the Bayesian risk as it's trying to do the prediction of uncertainty. And what we found by the time we compared to a baseline, so we had total of over 200,000 images across 86,000 patients. And what we did was every time it reached a certain threshold of uncertainty, then the prediction will be, I don't know this case, please radiologist review this manually. And by the time we did an evaluation, we found that while you're training, if you start to use this uncertainty metrics and you filter out certain data sets, by the time you start to filter out up to 20% of the data set, you begin to see an increase in performance. Here, you would see that when it comes to the positive cases, in the blue for fibrosis as an example, by the time you start to filter out, say up to 50% of the cases, or you filter that are uncertain, or up to 70% of the cases, your accuracy begins to go all the way to 90% in that sense, the F1 score, versus the baseline for the positive cases, which regardless of how much of data you filtered out, you didn't really get any advantage in that sense. To give you an idea of what this looks like, in this example, we also had a team of experts, 4 radiologists, who were going to basically look at cases and then try to agree on whether the labels, original labels for those cases, as to a certain condition, if those labels had to be changed. And what we found was that as we looked at the increase in the uncertainty score, looking at the graph towards your left, we saw that it correlated with the decision of the experts, the consensus of the experts, that the label had to be changed. So once you had low uncertainty, they agreed, without really knowing what we were predicting, that you don't need to change that. And as our uncertainty increased, they also saw that this labels need to be changed. And in a way that gave us the insight that this uncertainty prediction correlates very well with the way radiologists basically struggle to make a decision on certain findings in chest X-ray. And if you look at these examples here, the U hatch is basically the uncertainty prediction, and like I said, the higher it is, the more uncertain. And the P hatch here is the prediction of an abnormality in the location here that is mapped. And as you can see here, the more uncertainty you have, the prediction is quite low, below 50%. The last case here, you had a very low uncertainty and it was a normal case. So your prediction of any abnormality was also very low, further proving that being able to do this uncertainty prediction helps you know where the model should be very sure about the finding and where it basically has to say, I don't know, radiologist, I would need you to review this manually. And so to conclude, basically I've shown us, 2 different cases, one around uncertainty with reports another around uncertainty with computer vision being able to detect abnormalities in chest x-rays. And the one here in conclusion around the chest x-rays, one of the things I would like us to take away is the fact that predicting uncertainty correlated with the reader confidence. So in a way, we can basically have a way to know which kind of cases the model should be very sure about and which kind of case you should pass on to the radiologist, such that we don't have any missed diagnosis like we're seeing today. So I'll stop here if there are any questions. I know it was kind of, I had to run through this in a very short time, and I'll be happy to answer any questions that we have. Thank you. An acknowledgement to the NCI for the data that we use for the computer vision work.
Thank you very much for your presentation. I think we will first do the 4 presentations, and then we will get back to questions and answers. So the next one is now Jens talking about maybe the view from inside a hospital.
I actually also have a question, but I will answer it then.
Yes, yes. I have a couple of questions for you.
Oh, for me? Okay. All right. Yeah, great to be here. And maybe in advance, a couple of words. So I've been to several discussion sessions where the audience has not been engaged too much. That's why I'm maybe exaggerating a little in the upcoming slides. But yeah, you will see. So I want to ask the question, do physicians actually need explainable AI? And I mean, to cut a long story short, I would say no, we don't need it. And why would I say that? We actually, if I draw the comparison to medication again, we prescribe every day dozens of medications of drugs. We do not know how they work. So they are sort of a black box for us. Yeah, and we still use them because empirical evidence has been generated that they work and we can do better for the patients. And the second thing is, do we need to understand how, let's say, a machine works? Like, do we need to know how an MRI scanner works, the physical principles, even though if we could understand it? Or like if you do an ECG reading, do we need to know how actually the algorithm picked out the certain things over, let's say, a 2-day time period, which we then later on look at? And again, most of the physicians do not know how an MRI machine works, or how, at least to the very detail, or how the algorithm actually worked that picked the certain ECG signals. What we need to know is actually that, or if we generate output, like for example, a tumor segmentation or a tuberculosis segmentation within an image, we can see it with our own eyes. That's actually what we want to do. But we do not need to know why the machine said it, or why the machine made this kind of segmentation. Yeah, to summarize, what we need is actually empirical evidence, and that is, let's say, randomized clinical trials to determine the efficacy of algorithms similar to medication trials. We need explainable AI to build theories and actually improve algorithms. We need it for creating hypotheses. I think this is a really, really important point. So to understand relationships in the data and then either falsify or prove that this theory or hypothesis is actually right. So we need to ground it in reality. And the explainable AI is a really cool tool for doing that. And we can, of course, use it for quality control. For example, to discover shortcut learning, sometimes also called the clever Hans phenomenon, and to discover bias in the data. So explainable AI is very important, but might not play a big role, or I just say it now, it doesn't play a big role in the clinical practice if empirical evidence is given. Yeah. So with this restriction. So how do I see the role of explainability in healthcare? I think one point I want to add due to the previous talks is actually uncertainty. I think giving not only a result, but giving uncertainty to the hand of the physician is quite important. And this also links to established trust. So if we can trust, if an algorithm is always right, then after a while we trust it. And the trust can be established in different ways. For example, also using explainability. And what I also like to distinguish between is two categories of algorithmic output. The one that can be confirmed, like the segmentation example I gave earlier. And there might be, so I can see it with my own eyes. And there are scenarios where we have very complex and very large amounts of data with nonlinear relationships, where we simply cannot pinpoint to one certain pixel or one certain region in the image, but it's a combination of many, many things that might not be comprehensible by humans. So there is no way to use explainability to actually explain how the algorithm came up with a solution, because the relationship is so complex. Nevertheless, taking these two categories, for both categories, we do need quality control, and we can also establish empirical evidence for both categories. So even if we cannot comprehend what's going on, we can demonstrate under certain conditions for certain patient cohorts that the algorithm is in 90% of the cases right. And if we have established this evidence, we can use it, same as in the medications. And maybe another point, I believe that explainable AI and the methods we have seen, and maybe we'll discuss later, or which are out there in the literature, are really fundamental for building up an AI theory. Yet, even if we do not have the theory yet available, this should not prevent us from using these algorithms already and do good for the patients. And with this slide, I want to conclude. So if you imagine we would have waited for the thermodynamics theory to exist before we would have used the steam engine, we wouldn't talk about today about AI. I truly believe that, because it took more than 100 years to establish a theory after the machine has been introduced and started the Industrial Revolution. So this is maybe one point I wanted to make, and also maybe a link to the GDPR, and many people interpreted that we need explainable algorithms to use it. If you talk to, or I talk to several legal people, there's room for interpretation there. And the point is, we should start using it in a controlled setting by using empirical evidence. And I think this is, this is it.
Thank you very much. I hope that it will spark some discussions. And then the last speaker here is Mina. And open your slides.
Okay, so hi everyone. So my name is Mina Bielagovic. I work in a lab led by Professor Levis, where I organize the part on data science, mostly on machine learning algorithms. And we are, that's why I want to speak about our context. We have three legs. Let's say we have a AI part where we develop algorithms. We have a part where we speak we work a lot of semantics, but as well, a part that is very important, maybe on the discussions we'll have later. I'm not a specialist, but there is a lot of people that should work on human factors as well when it comes to interpretability. And just a bit of context. So we are a research group at the Faculty of Medicine, but we're as well a division at the University Hospital. So we are kind of this big institution where people interact with machines, produce data that will then be used for everyday interaction, applications. And in all of those new applications, but not only new applications, there could be room for AI and deep learning methods. Just to stress out that this year there has been a lot of new opportunities and maybe pressure as well from big companies that are providing us with the big large models and that have like very good performances on some tasks. So just keep that in mind. So this is let's say where I work. And the reality today is that, okay, so there are huge, big hopes in AI, but when you ask like simple questions, like how many COVID patients there is, at the end of the day, it's not automatic at all. It takes a lot of time. And there is many reasons for that. And, but context, again, that's why I wanted to start with that. Context is very important. And then, so on one side, we use very few of this data at the hospital for applications that we could think of. And on the other side, you have like Dr. GPT, an app that you can ask. Like here, I kept it in French because we speak French at the hospital. So like a general question. So my patient is ill, has this and that symptom, and it will answer something that is really astonishing. I mean, at the end, I mean, it's in French, it's technical, it's medical, and it gives like a good answer. So you said, okay, let's use it at the hospital. But then you can very easily, and you all maybe played with it, you can trick the system very easily. You speak about difficulty of speaking by the eye or hair hemiplegia or something like that. And it's completely, again, answers a completely kind of normal answer with no uncertainty and saying, okay, yes, your patient has as well a stroke. It has no sense. Okay. And so my first key message would be like, okay, so the knowledge is not intelligence. I guess in this room we all agree with that. So we need to make sure that we appreciate the true capabilities of these tools, and this can come through explainability, interpretability. As well, there is the AI Act, and it's interesting last presentation as well. It's true, but it's now with high-risk applications, we will need to provide transparency. So it's even a more strange word, transparency, because it's, again, it brings other aspects on the whole problem, but maybe just to, okay, I'm missing one slide, but sorry. There is, okay, so for transparency, there is 3 categories in my view. There is one that, okay, we should be aware that there is AI. We should like explainability, explain maybe the model, but as well be able to pinpoint on this specific case what elements did the model use to make its prediction. So here it's a radiography and chest CT actually, and you need to, the model was trained to detect a pneumothorax. It has very good performance, but then when you look at the false positive, you get, so you have these maps that can show you what the model looked at to make its decision, and you see that it actually looked at the drain. So it's a very good drain detector, this model, but it's not at all a pneumothorax detector. So it's beyond being completely useless. It's even dangerous. So that's why here with this kind of methods, with post-hoc interpretability methods, you can start to build trust. However, if I tell you that there is not one method, but there is plenty of them, and that maybe another method that I could use to explain my model could give me this kind of interpretation. Which one should I choose? And maybe so the first point I would like to stress out is that this decision on which method should be used should be independent on human judgment. So we should find a way not to say, okay, as a human, which one do I prefer to look at as an interpretation, but to really quantify which method actually really understood what my model used. And so interpretability methods evaluation is as important as interpretability itself. We need to trust the methods. So this is a paper that we published this year. And basically, generally what you do, you have a model, you have a training set, and then you have an interpretability method that will tell you, okay, this part of the signal was relevant, was super important for this decision on this particular case. So how do you evaluate? You can corrupt, so you use perturbation techniques, basically remove the information in this part of the signal, and you compare the drop-in score. So if you remove everything that the model used to make its prediction, normally you should have a big drop-in score. Okay, so this is how you evaluate. The problem is that with this, you have a shift in distribution. So your training set, so the model, the data, and this is basic in machine learning, it's that you cannot evaluate on the data that is generated from another data distribution. Okay, so this is a big key issue. So there was a nice paper, the ROR approach, where basically what they did is said, okay, so to evaluate, we do perturbations. So let's retrain the model. And then let's see the drop-in score. The problem with this approach is that actually you compare two different models. Okay, so, and so our proposed approach was, okay, having adding perturbation in the data set is a good idea, but let's do it in the training set already. So you augment the initial data set. So by that, you basically can evaluate your model with perturbation because there is no distribution shift. And at the end of the day, you, and this is my second very important key message today, is that you need to evaluate exactly the model that you will be using later on. And so in this jungle of post-hoc interpretability methods, so for example, you have an ECG, you train a transformer to see the absence or presence of a left bundle branch block. You have 4 different interpretability methods, and we developed metrics to say, okay, the Shapley value method for interpretation is better than, for example, kernel Shap. Just for the little story, so that you understand that I will not go into detail into the metrics, but the black line is actually if you do random assignment of important points in your signal. So basically it means that this interpretability method actually is not performing better than just randomly assigning which part of the signal were important for your prediction. And by that, I would like really to thank a lot the people that work on that, especially the PhD student, the first author, Hector Bay, that worked on that, Professor Lovis and Professor Gianmarco Mengaldo, that is in Singapore. It was a very nice collaboration with Singapore. And maybe to finish, I think a good question to have is like, where do we need interpretability? Where do we don't need interpretability? And there is different ways to arrive to the top of the mountain if we want to arrive to the top of the mountain. So with that, thank you.
Okay, so thank you very much for the presentation, the panelists in presence and also online. I mean, I have a couple of questions for you, but are there any questions from the audience? Well, we can start with that part and then I can come back. Or do we need to start ourselves? I mean, so you mentioned this aspect on, like, first of all, find that the interpretability method looks into the right places and actually finds what is distinguishing, like a specific decision that was made. How can we explain this actually to, I mean, how can we do this in a way that an end user would understand it? Because it's not necessarily trivial. if you look at like hundreds of millions of parameters and say like, oh, these layers, I mean, these neurons are responsible for that. How can we go ahead? Or
sorry. So this is model explainability. We don't do that at all because I mean it's really complex to understand. But what we do with post-hoc interpretability is really we pinpoint on the sample, so on the specific case. What did the model use on this specific case? So we don't go at all into model explainability, which is very complex. And
so you look at single decisions, and
yes,
but
exactly.
you could generalize it for
I mean,
a certain number of decisions for a specific disease or a specific grading stage.
Yeah, then you can kind of, but then it's another step, which is like motive discovery. So you want to find motives from a lot of samples and see what was common in all of those samples, and maybe go to the motive and then try to understand, speak with clinicians, and maybe say, okay, is this motive? Is this, for example, repolarization? Okay, for example, in ECG, so we work a lot on ECGs in our lab. I say, okay, is the repolarization part of the heart played an important role for this disease classification? So is it something that is known by clinician, or is it something completely new? Mm-hmm. And then we can go to medical discovery, but then it's
exactly, that's I think what Jens also said about I think it generates hypothesis, and I think that is something that can be really, really important in for like ways of using interpretability tools. And again, like it can be used to like find bias in the data, also problems with the models. Yeah. So Jens, you mentioned that it's maybe useless for clinicians, or clinicians wouldn't use it. I mean, I've had the feedback quite often, well, these cases, I mean, it's so fast, we don't have time for using that. So would it slow down physicians, and how would we be able to actually use it in clinical practice?
I think you need to find a good task which takes a long time to use these methods. For example, the chest X-ray example, or examples we've seen, and I think it was 1 minute and 38 seconds, the average time. You're so fast if you're doing this. You have your microphone in the hand, you dictate it, you look at it, you dictate it, and you're done. If you get a explanation, or if you get even a report pre-written, there's something wrong, or you have a certain wording you use, and you start correcting, it will most certainly take longer, as if you would have done it without the machine. So this is really maybe not the right task. On the other hand, there are certain tasks which are quite tedious and take a lot of time. And for example, if you have multiple sclerosis and look at different lesions over time, or there are certain like metastases in the lung, or lung cancer, where you might overlook a certain region. And if you then get a heat map that brings to your mind, oh, this is something I didn't see because I was in clinical routine, time pressure, and then it pinpoints you to a certain region, and you can either decide, yes, I take it into account, or no, then it's important again. But the task has to be well defined.
Yeah, no, I think I mean, I think in general for AI, it's not just because we have data, we should use it and try it out how well it works, but really looking at specific tasks, I think where help is required. I mean, non-trivial tasks that are difficult, that take a lot of time. I think that's where you can actually show what AI can do with healthcare data.
Actually, maybe add also to the chest X-ray example you have shown, and I think this is a perfect example where for probably the user it doesn't really matter which heat map you present. But they're both the same, because you look at the right region of the image and then make up your mind. But to understand the methods and then further develop the tools, so this goes hand in hand. Yeah.
You know, I mean, definitely. I mean, chest X-rays, I think, are by far the most frequently used images for anything in AI. But just because there are so many public data sets as well, and that are annotated, that are available, accessible. I think that's good. Yeah. Andre.
Yeah, I think those methods of explainability, they go beyond as well just doing clinical examination, but they could also help, for example, a newcomer to learn about things they should look at, right? So this type of application, or to be able to say, oh, maybe this here is not so right, and to help us debias finally the algorithms. Right? So I think there are applications that go beyond maybe just, you know, the obvious clinical part, which is diagnosis or understanding.
I mean, definitely. I think some things that were also mentioned. I mean, we should not only look at things where we try to imitate humans. I mean, that's the definition of artificial intelligence. We're trying to do what humans do. But actually, many of the tools can do things that humans can't do. And I think that is something that AI should also focus on. Because if we look at abstract textures, I mean, humans describe it. And if you use interpretability tools, I mean, it's extremely difficult to get anything meaningful out of it. But you can still say that this is relevant for a classification. Sometimes this might actually lead to new hypotheses and new findings in that respect as well.
Yeah, I can't take the mic from Henning, but at least I can comment a bit here. So great discussions, and I think one of the other things that was pointed out around how quick the radiologist has to look at chest X-rays is very, very critical, because sometimes it's not so much knowing that you have to do it fast, but also knowing which ones do I do first, right? Which ones are really, really difficult versus the ones that are just, boilerplate. I can tell the resident to do it and not spend time on it. And maybe that's where some of these models have to be very, very certain, or at least be able to pick up on certainty enough to say, this is a difficult case. I'm not going to bother showing you any heat map. I'm not going to bother showing you any abnormality. Please do it yourself. So that's another use case I think we can explore, how models could basically help with triaging such that physicians use their time more effectively.
Yeah, no, definitely. I think there are a couple of cases where time can be saved. I mean, triage is one of the things, because you can look at all of the images and very quickly make a decision, put an order. Like if you look at emergency radiology or these kind of settings where you need to take decisions very quickly what to look at. And if a case is behind in the line, it might be read too late, actually. I have a question for you, Dimitri. So when you work on with Siemens on such tools, do you run user tests? I mean, what is the feedback from users on these kind of interface? I mean, you have quite a few tools, plugins for your readers, etc. How do you evaluate that?
So we typically run user tests. Sometimes we do it such that it's a group of users without the tool, and then group of users with the tool, try to match their expertise levels together, and then see what impact these tools have. The other thing we try to assess is what is the amount of disruption this tool is bringing to the workflow, because I believe it was Jens that highlighted it, that sometimes it's like I would actually, be faster if I do this myself than having the AI tool help me, because then I have to look at the report and edit the report, and that is taking up more of my time. So we also try to.
So what was the outcome of these studies? Is it faster? Is it slower?
Yeah. So most times what we've found is it can be very disruptive. It can be very disruptive bringing this AI models into the workflow. And so what we try to do is find out at what stage in the workflow would it be least disruptive, and then bring it in those stages. And that's where we're seeing more of the success.
And are there changes over time? I mean, particularly, I think when any new tool that is being used by a clinician or by any other user, slows people down. I think that's quite normal. But what is the learning curve? Can you observe it, that it quickly gets faster, or?
It's a thing where it's also, you would see a little bit of subjectivity in that learning curve, because some people are early adopters, fast adopters, and some are not. And some people are very tolerant to say, if this thing slows and adds a few seconds of 1 minute, I'm fine with that. And some people are unforgiving. So it's very subjective. And what we've found is when you have the forgiving and early adopters, the learning curve is much steeper and they quickly get used to the tool. Those that come in with a premonition and bias already, there's really not much progress with them.
Okay, thank you. So any questions from the audience? Yes, there's one in the back.
Thanks. More than a question, it's actually a comment. I didn't hear much about the fact that actually looking into interpretability and explainability of the models can actually improve AI and help us build better models, right? So this is not something, because we're always thinking about the applications, but that's actually what's happening in the background. Maybe in these big firms, they go from one model to the next, right? So I think this is, especially if we work together then with domain expert, isn't this something that it's important?
First of all, I totally agree on that. And I mean, we had some experiments where we used pre-trained models, where we used ImageNet, for example. ImageNet has like many objects in different sizes, so it's scale invariant. Usually when we use medical images, we know the scale, so we don't need scale invariance. So what we were looking at, what are the parts of the network with our interpretability tools, regression constant vectors, which of the parts are relevant for the scale invariance, and then deactivated them. We massively improved performance because, I mean, the more we understand models, I mean, we can manually also modify model. We lose some of this beauty of like automatically finding features, but on the other hand, I mean, the understanding definitely helps us to also improve results. I don't know if you have other examples for that.
Yeah, I think one of the points there about it, when it comes to the model itself, it's one thing, but it's also about the data you use, right? In terms of training the model. And one of the key points I find, which is quite important, is the biasing, right? So what are the invariances that you need to actually remove from your data, or that you can count on, you know, not needing to operate on? I think that's quite an important. So this would allow you to affect that. However, I find particularly that even more in the intersection with healthcare, that the most important thing is really to help the human actor there to understand what's going on. Though understanding for us engineers what is going on within the actual algorithm is, of course, an added bonus, I would say.
No, I think, does that answer your question? I mean, if you have any other comment, just please follow up on that, because I think it's indeed, I mean, it's important. One of the things we haven't, like, I mean, Mina mentioned it a little bit, but we haven't specified it specifically. I mean, there are many different levels of explainability. I mean, we can do it on the level of a specific classification, a specific case, or we can look at the underlying data. I mean, that helps, for example, to identify biases in the data. I mean, there's many biases, male versus female. I mean, there's many other biases, because whatever type of training data we have, it depends on the population. If you look at medical data of the specific hospital, and a hospital in Geneva might not have the same population as a hospital in Sion, or a hospital in New York, or in Beijing. I mean, that varies definitely. And then we also have a specific model that is trained on data that can also have these specific biases. And I think we can have interpretability on all of these levels. And I think that's what we would need to take into account if we want to make practical use of it.
And also the quality assurance point I made. So you can use it if you deploy the model on a new site, and see what features are relevant, and are they the same features, for example, as the model was trained with, or then in Geneva versus Beijing.
Maybe I have a follow-up question about you did the parallel between medication and these models. So we don't understand, but we use medicine. The big difference that I see is that medication is fixed in time and does not depend on trained data. So how do you deal with so you deploy a model, but then you need to fine-tune it, to train it, retrain it, to keep the performance, because you will have maybe new kind of machines, new kind of data, new kind of acquisition systems. And with medication, you have like generations of human cobayes or people that tested it. So you're kind of confident that you can use it. But with AI tools, every 2 weeks, like with ChatGPT, you are like a new generation of cobaye.
Yes, I mean, you would you need to run through these trials again and again, and the evolution is much faster. But I would say, for a certain heart medication, it was the trial was run on a certain population, white males, 50 to 60 years old, and you determine the dosage to be whatever, 35 milligrams or whatever. And now you give everyone the 35 milligrams, and we are all different. And so this is actually where real world data should kick in and actually then also be adjusted, because we are individuals, and as the name says, so we should also receive individual dosages. And so it's a sort of similar, I would say.
Yes. Indeed, it's like average evidence, and usually, I mean, for stroke or like a heart attack, I mean, it's examples where all of the guidelines are based usually on older males, older white males, and
it's dumb example, but
I mean,
it's usually
it's much rarer in females, but mortality is much higher because they're often misdiagnosed, they're underdiagnosed. I mean, there are many examples of that.
No, I find this is also a very interesting application for explainability, because if you're, for example, detecting a disease and you are finding that there are parts on the image or on the data that corroborate that particular disease, and you apply treatment, then you're expecting that the areas which are affected are going to reduce in time eventually. So that you could use that to personalize better treatment, or to understand treatment, right, for that particular individual.
Yeah. Any other question from the public? I mean, otherwise, I have a question, I mean, for all of you. Often we talk, I mean, we had, Dimeji talked about interpretability for text and then interpretability for images. You mentioned you use signals. What about multimodal interpretability? How can we do that? Because, I mean, medical data, there's many different sources. I mean, you might have genetic data, you might have signals, and you have data over time. How can we actually integrate that? How can we develop tools that explain these types of very complex data sets? That's what a clinician is facing, and that's what's making the task quite often difficult. I mean, if you have cancer, I mean, you have a whole history of like anamnesis and possibly prior cancers, etc., family history. I mean, how can we pull out those points in the data that are relevant for that?
Okay, this I don't know, but we have some projects where basically we use the gold standard, which is like for cardiac illnesses, we use the cardiac MRI and to annotate our data set, but we annotate the ECGs. So like this, we want to see if in the ECG we can see something that before we don't know how to. So we use really another modality. So that's the way how we incorporate other modalities, where we annotate different modality with the gold standard that is not the one that we use to train our model. And then, okay, but it's true that I haven't seen any interpretability method because as well, there is very few models that use different kind of modalities, first of all.
I'd say that maybe even a problem that is before multiple modalities, which I totally concur, it's a very good question. It's like longitudinal studies. Is like what changes from point A to point B, and how do you explain the change, right? Also with effects of medication or prevention or whatever, you know, you deem.
This is a very important point. So health is a continuous state, right? It's not a snapshot of time, which is also often not considered by methods yet because maybe the data is not available. And the other, probably, again, the data is not available usually to characterize a patient multimodally. So then you have to deal with missing values on the one hand, and you have to decide how to fuse the model. So do early, mid, or late fusion. And then theoretically, you could apply many of the existing methods to then discover relationships.
Because I think it's very, I mean, there's a lot to be learned, I think, by doing this smart. We do that on like histopathology, where we look at like concepts extracted from text and image, and we have some clinical data. And when we do this multimodal learning, we get much better results. And it's actually really interesting with with no manual annotations. It's also really extremely good.
Yeah, so we actually also observed this not only multimodal, but also multitask. So if you do both things, the results tend to get better. Yeah.
So we'll have like large multimodal models at some point with trillions of parameters. There's also a comment in Speak Up. So So if the physicians, I mean, it's a long comment, so I will read it for you. So if the physicians don't need to explain the AI and in fact can't, someone should be able to. Taking out that human factor is problematic considering the rampant bias that exists in healthcare and will exist already with AI involved. If the physicians can't explain to a patient how the diagnosis was brought about, then the patient is less able to make decisions regarding their own healthcare. This is a slippery slope to go down, and while the physical might have total trust in the AI algorithm, the patients will not, especially coming from communities that have been historically adversely served. Perhaps there should be an intermediate medtech specialist to be able to handle the explainability of the cases. This would serve to both protect the physical hospital, the physician, hospital, and the patient. It's going to be decades until algorithms are unbiased, and until then, explainability should be an integral part of AI ethics and equity in treatment. I totally agree with that point. I think it's important to have the human in the loop. Somebody also needs to take responsibility. And I think building AI tools myself, I mean, we also know some of the limitations, and sometimes they come along surprisingly. And I think it's important to have somebody doing like a qualitative check and say like, okay, no, there's a problem here with that case, and there's something here. I'm not sure that a model can be unbiased, because I think a model is like any AI model is based on the data that we have. And can data be unbiased? I don't think so. I mean, we have.
Sometimes it's even favorable, right? So we know that certain ethnic groups have a prevalence for certain diseases, and this is a strong prior. It's genetically grounded or whatever. So why not use this fact, right?
And I mean, that's also why, by definition, you will have more people from these communities in for specific diseases. So whenever we train a model for these diseases, we'll have an unequal representation. I mean, people coming to the hospital do not have the age structure of the population, neither the socioeconomic structure. So, I mean, I think all data sets are biased, and like that, all of the models are biased. It's just important to understand the bias and to be able to explicit it so people can deal with it.
Right, totally concur. I think bias, like performance, is not something that an engineer would take care of. I mean, it would take care of making sure that the system is maximally usable, but then who decides on the threshold for the system application? Who decides what are the ethical boundaries, or what is the fairness constraint that must be applied on a certain institution is the problem of that institution. And it changes with time as well, right? Mm-hmm. So people have discussed here fairness and bias in general, but I think it's very important, and I think this relates as well to explainable AIs, to be able to understand bias across time, right? Your population, there is no guarantee your population won't shift in 10 years. There might be more immigrants. It might be, people from, I don't know, another canton, or climate change. It might change, completely the picture of how you're deploying your particular AI solution. So to my understanding, there should be constant monitoring. And I think XAI, or explainability, is one of the keys that enable that check, right? That constant check.
Yeah, definitely. Mina, you want to say something about that, or?
I was going to say something around that. I think it's a very, very interesting topic, because at the end of the day, we are really at the verge of seeing more generalizability in the models, right? And by definition, generalizability is basically around what are the commonalities, right, between this data that was used to train and the data eventually it's going to be used to test with, or when it's deployed, when the data is going to work with. So as much as we want to make sure that bias is represented to a very great extent across the population, we must also see that the model is effectively learning commonalities, because that's where generalizability will help. What are the common? We will always have, and I agree, there will be shift in population, shift in immigration, but there will be some things that will be common across time, right? We need to see that the models are learning that effectively, and not just the biases such that we have to retrain them every single time there's a change or there's a new bias. So our focus should be how much of those commonalities has it learned, and then what are the additional things in the instruction tuning and fine tuning we have to do to now have it focus on a certain population.
There might actually be a link between the bias and what you presented in the correlation of the expert errors and the predictive uncertainty, because you could assume that the more difficult images were annotated more ambiguously, and therefore it's built in that the model, because it was trained on that data, has more uncertainty.
Yep.
Definitely.
Yep. Very true.
So another question.
Thank you. It's not a question, it's some remarks. Sorry. First, I think that in the problem of the BS and the data is not well handled today. From a company perspective, from the regulatory perspective, generalizability is very important. From a healthcare provider, from a patient, singularity is very important. And we are all biased. And what I expect when I go to a physician is not the commonalities, it's my singularity. And personalized medicine is trying to promote the handling of the singularity, not of the commonality. I think engineers, they should more be concerned by the algorithmic bias than the data bias. The data, they are, and I agree with you, they are by definition, they are biased. And thanks God they are biased. Because if they would not be biased, we would not need to see any patient anymore. We would just take a model of a perfect patient and voila. So this is very important to me. The second point is about explainability and interpretability. And I know there is a lot of debate in the literature about what is explainability and what is interpretability. But actually, interpretability is important to justify the handling of the decision of the user of AI. Because these people, they are also facing liability, they are facing responsibility, and they prefer to take decisions knowing why they take decisions. And this is where interpretability plays a very important role. And it's the same with paracetamol and metformin and many of these things. We don't know how it works, but we know that if you take 50,000 people who have a certain type of disease condition, you give them paracetamol, they will have less pain. Voila. And this is enough. It's a justification. And one of the problems today with the use of AI in healthcare is that it continues to be a black box. And for many reasons, there are cognitive and behavioral and algorithmic bias that are deeply put into the different systems that we are testing in hospitals. And they are not transparent to us. They just give us a risk of pulmonary embolism on an X-ray with a positive predictive value near 0 today.
I totally agree that I think in terms of algorithmic output, I think we need the feedback of something. I mean, when you look at you mentioned the effectiveness of medication. I mean, that is for me pretty much generalizability, because it's on average it works. So it sort of works for part of the population. That's not yet individualized medicine. I mean, I also think that in that respect, we would need to go towards something individualized, singularity. If it doesn't work for me, I might not be happy. As a clinician, I mean, that is something, how can we find out these patients and when it would work, or what kind of dosage we need? I mean, Jens mentioned that in his medication example as well. And I think there's still a lot to be done.
Yeah, I'd just like to complement that. I mean, when you buy 1,000 milligrams of paracetamol today is 1,000 milligrams of paracetamol, whereas I think Mina's point before was also quite important, which is like there is new versions of AI coming out. So it's like there is a new paracetamol coming to the market today. And how does that going to impact actually my cohorts, right?
But I actually do like the paracetamol example quite a lot because it's used for children. It's a common medication to lower fever actually. But it's quite dangerous. So if you overdose, you get problems with the liver and you can die. And you need to know basically the boundaries. And the same actually is also true for algorithms.
Yeah, totally agree.
Yeah. Oh, sorry. Yeah, I have a question for the about uncertainty. So is it where it's uncertain that you can have some medical discovery? Because basically when you annotate from, for example, one modality and you train the model on another modality that is maybe cheaper, faster, whatever, because you want to improve patient care, you want to diminish the costs, etc. You don't want to have a new tool, basically, that can be maybe effective with AI and cannot be effective with traditional methods. But very often you cannot see really, because on this sample, you cannot use a medical expert to kind of double check, okay, my model used that part of the signal because the physician never used this modality to diagnose. Is there the way, because I mean, for me, explainability, I mean, interpretability can be used for medical discovery a lot. Do you see a link between uncertainty and room for medical discovery?
I do see a link, but with a lot of caution, right? Because we cannot be quick to say if the model discovers something, right, that wasn't in the ground truth, for instance, right? That, oh, this is a discovery. This is something that basically the doctors missed, but the model was able to catch, and so that can happen. But we also have to be careful to say we need more elaborate studies. We need more rigorous evaluation to see if this finding was an artifact or actually something real. So what we need to do is try and see how, when such things are discovered, we take the pains to say, okay, can we see similar cases, right? And see if that same finding is there, right, that we have missed, and go through the right scientific rigor before we're quick to say, oh, you know, this AI can be used to discover some new things. So I would say, yes, there is an opportunity, but we should do it with a lot of, you know, rigor and caution before we're saying, oh, this is something that the AI has discovered that the humans did not know. I would add, you know, to the very, very insightful comments on singularity versus commonality. Let's not forget, and I trained as a physician, you don't start out learning the specialties. You start out learning the basic medical sciences. What is normal? Your normal neuroanatomy, your embryology, your physiology, because you have to start with commonality. What is the common thing you would see in a normal case before you go on to the specialties? And in training models, we need to replicate that, especially in healthcare. We need to replicate that. Know what you should see, and then start to see the deviations from normal, right? So as much as when you go to see your physician, they are focused on singularity, I agree with that, but realize that they have been trained on commonalities for a long time before they got into those specialties. And that's why they could start focusing on singularity. So we need to bring in that aspect into training models also.
Please go ahead.
I agree with you, but the problem is that when we train with data from patient record, we only train with singularities that are not the normal situation. I had another point which I wanted to stress. I don't remember who raised the point. It was about the temporality or the time window or the continuous property of biological mechanism. We have seen during the COVID crisis about 400 papers that were using AI to predict the behavior of the SARS-CoV-2, and none of them helped, actually. And this was mostly due to the fact that once the data were available and the model was chosen and trained and robust and whatever tested, it was a new variant, and the model was predicting the wrong variant. And temporality is a major property of biological phenomena, and temporality is badly handled today in algorithms.
I totally agree. I mean, there's also a lot of like human intervention. I mean, when we look at COVID, if you want to predict it, there's intervention. I mean, if you try to predict nosocomial infections in hospitals, and you know that whenever you have statistics about what happens, people actually react to it. I mean, it's an ill-posed question. If you're trying to predict something, somebody else intervenes on it. It's the same thing with COVID. I mean, if you have a lockdown, it's completely different behavior afterwards than if you don't. And so there's so many different parameters that, I mean, sometimes we also need to try to see our limits of what we can, or what we try to predict, and where it actually makes sense, I think.
Yeah, right. Yeah, I think that's totally true. I'd like to complement as well on something that was just said before, is that I don't know to which extent, and this is maybe a question to the panel and to everybody here. So we're basically kind of getting to the conclusion that for an AI agent to be able to discover, it needs to be very good at the basics, right? So it needs to agree in all the basics. And so this means for us to be able to build such a system, we need to regularize it. We need to put constraints on it and say, okay, you have to be very good at the basics, but you also have to be very good at discovery. And I don't know to which extent, these two things are antagonic.
I mean, definitely. I mean, that comes back also to something that Christian said before. I mean, there are quite a few biases in there. There are things, I mean, that are in a hospital. You, by definition, I mean, you have people who have a problem, and if you try to do predictions on that population, you need a model that corresponds to that population. And it's the same thing if you want to do that in Geneva. I mean, you need to look at people in Geneva and in a specific hospital. University hospital does not have the same population as smaller regional hospitals, because all the complex cases get there. And again, that's what you want to have in your model if you want to do high quality predictions. And you want to be the model based on your population. So I do think there's an antagonism in it. Otherwise, you can train with healthy people and look at anomaly detection. I mean, that's a very different problem, I think.
Yeah, right. Yes. Well, yes. I was trying to evoke the antagonism between a model that knows a lot and the model that has to look for novelty. So
yeah.
That's actually the point I wanted to make with that change. So
okay, perfect. I think we're asked to wrap up. So thank you very much, first of all, for the panel, Dimitri, also at a distance. So thanks a lot for your input for this session. I think most of us will be around, so if there are other questions, don't hesitate to come up to us. And thanks a lot, Stephen, also for running everything, for making sure that we could use Zoom for this. So thanks for your attention, and don't hesitate to contact us if there are further questions. Thank you.